So I'm Muredach Reilly. I'm speaking on behalf of my colleagues in the Irving Institute for Clinical and Translational Research, the Irving Institute. There is another Irving Institute at Columbia, but this is the one at the Medical Center, and it's a big clinical translational research mission. And I'm going to talk about our COVID research initiatives and services. So what is the Irving Institute, first of all? Well, the Irving Institute is a university-wide institute based at the Medical Center that is supported by a university endowment from the Irving family, like many others. And it has a big grant award from the NIH from NCATS called the Clinical Translational Science Award, the CTSA. And this sponsors up to 11 programs or 11 resources across a broad variety of areas of research, from precision medicine to community engagement and clinical research. And we have over 70 faculty who are engaged in our programs as leaders for the different aspects of our programs and engaged to execute our mission. And we have over 60 staff that work with us. And our CTSA award in our institute is one of 60 CTSA awards to similar institutes nationally. So we also have a function in national networking and national engagement, which is relevant to some of the conversation today as well. So I'll talk a little bit about the Irving Institute, then I'll talk about our COVID initiatives and services, and then how to contact us and leverage our support. So at the top of the screen, you can really see, what is the basic fundamental mission of the Irving Institute. And it's to advance our discoveries and knowledge and innovation to improve human health across the lifespan for our diverse populations in Upper Manhattan and around the world, particularly Columbia's global university, and we're part of a network nationally. And we have, as I described, we have 11 programs or resources, which you'll find in detail on our website. And we also have several 4 to 5 interdisciplinary initiatives, which are kind of new initiatives we start, and we either continue into large programs or we retire after a couple of years, depending on the type of impact we're trying to have. But from a service perspective or a support perspective, we really are a support organization for research. And we divide ourselves into consultative support, research support services, funding, education, and training and mentorship. And so, for example, consultative services are very relevant to what's going on in COVID right now. With respect to things like design and biostatistical analysis, which have been the foundation for a lot of the clinical trial designs that are going on in COVID at the Medical Center and beyond. And of course, the IRB regulatory aspects, as we do the biobank, there's been really cutting edge regulatory aspects in IRB necessary, and informatics or with biomedical informatic colleagues as well. And research support services, you have similar type of kind of a level of services and support, particularly with community engagement, clinical research space, multi-research engagement across the nation, and including grant writing support. So some of these have been very much leveraged during the time of COVID, and others, for example, our education and training is not rapid cycle like COVID, but we have a K, we have a T, we have a master's program, we have a summer research institute, and we have a support mechanism for writing funds. For the first oral one writing, we provide a course over 3 months to help people write their first oral one, reach for the first oral one. In pilot funding, we have a significant portfolio of over $1 million a year of pilot funding. And we've already launched 4 separate pilot awards towards COVID research since March, April of this year. 2 of them with the Cancer Center and 2 with other partners as well. And I'll talk about those a little bit later. So as of March 5th, I think at March 7th, it says on the slide here, this was a summary of what we were doing and why March 5th, March 7th, or May 5th, May 7th. This was the day that we submitted our 5-year CTSA renewal. And for anyone who's trying to write grants, writing a CTSA renewal during a COVID pandemic was not the simplest thing in the world. But this is when we submitted our CTSA renewal, which is a 5-year renewal award, and it's undergoing review currently. And we had already established significant strategic planning, infrastructure, and seed funding. With pilot awards already awarded. We had started to support clinical trials. We had initiated the biobank with partners across campus. We've been working with our biomedical informatics resource and Department of Biomedical Informatics to generate data, clinical data for COVID-related research. And we've been extensively engaging with community at that point. So let's dive a little deeper into those areas, just to tell you what's updates and going on in those areas since earlier in the year. So for clinical research data, can often be considered to be electronic health record data and related data that we coalesce from the electronic health record, now EPIC, working with Department of Biomedical Informatics. We have a resource and a program called Beamer Biomedical Informatics Resource, which is a collaboration with the Department of Biomedical Informatics and other systems biology too, for that matter. But in this case, really focused on EHR data and clinical data. And working through that mechanism, we first developed the informatics supports towards the biobank, the LIMS system plus electronic health record data. We also established clinical data navigator services that were targeted to help people on COVID projects. So a consultative service to help people who are not familiar with clinical EHR data. And we have a consult service there. There are multiple data navigators, the medical center, but we provide one for departments or domains that don't have one. And then we've been participating through the Department of Biomedical Informatics and our Biomedical Informatics Resource on this large NIH NCAT sponsored initiative to coalesce all the clinical EHR data that they can coalesce from all the medical centers nationally, called N3C, which is using an OMOP framework, which is the framework which Odyssey and George Tripchak has developed, but it's a national initiative that's been led out of Hopkins with a lot of support from collaborators at Columbia to coalesce this N3C large-scale COVID clinical data resource, which will, I think about, at this stage, is about 50 institutions that are contributing data, have started to contribute data. They're cleaning it, coalescing it, and it's updated once a week or so. Data use for this will start in the next 4 to 6 weeks, and data use agreements for all of the institutions will be flowing from NIH and NCATs in the coming weeks. And we've also developed tools with our bioinformatic medical information colleagues around looking for trials, a bit like you heard in the previous talk. How do you find trials that are going? Actually, this is a trial finder that you can find on our website as well. So clinical trials, at this point, the services of the Irving Institute and the CTSA have been used to support over 16 COVID-19 clinical trials at Columbia. And we've launched a dashboard to identify demographics of state COVID-19 reporting dashboard around clinical trials. A lot of the support for the clinical trials have been immediate around design, statistical analysis for trials that started in March. And then over the last couple of months have led to the design and analysis and grant collaborations towards larger grant submissions. But Xing Li, Ken Chung, and our colleagues in our resource who works in Mailman Biostatistics that we support have been providing this service. And then at the national level, there's a Trial Innovation Network, which runs across all of the CTSAs and all of the institutions across the nation to do national trials. And their NCATs through the CTSA is running a set of trials in the Active One program. And that's actually started in the last couple of weeks to enroll in their first trial. Fortunately, we're not in a good position to contribute to that, but you know, we are part of the membership of that list, and we allow our investigators to engage in national trials, or we facilitate investigators involved in national trials through this mechanism called the Child Innovation Network, or TIN. We've already been doing this for the last few years with some success at the national level and leading trials out of Columbia through the TIN network. Perhaps the largest biobanking initiative nationally that we're aware of, really around COVID, started here in March. We were fortunate to work with partners in the Office of Research at the VPNS and Columbia Medical Center and multiple departments in biomedical informatics, the Institute of Genomic Medicine, pediatrics, and many others, systems biology included, to establish a biobanking protocol, pivoting and establish university-wide biobanking protocol, and started enrolling patients in April. By the June 15th, as you can see here, we've enrolled and consented participants, the 1,500 participants for full genomics and precision medicine related biobanking. And on the bottom, you can see that we started in April and May to start giving out samples. And we've just completed whole exome sequencing on the first 1,500 subjects with IGM and David Goldstein. And that data will be available pretty soon. Andrea and Saigi and others in systems biology are generating RNA sequencing data in materials derived from nasopharyngeal swabs, and others that are in this biobank also. So briefly, the number of samples in this biorepository is about 7,000 for 8,000 patients. There's approximately 15,000 subjects in a REDCap database related to this, over half of which have COVID. And there's almost 2,000 subjects consented for deep precision medicine genomic studies. There's over 1,000 participants that deceased, unfortunately, but they are also included in the biobank repository and are obviously very important in terms of the outcomes and understanding risk for outcomes, genomics, and social determinants of health. We have a questionnaire, and all of the participants in the biobank have signed consents, and that is over an 80% response rate for a fairly deep questionnaire that is available. And samples have been started to be distributed already over the last month or so, with over 50 requests for samples having been met. Not all at this point, but many and most, including urine, feces, blood, nasopharyngeal swabs, DNA, and beginning to make available genomic data as well. Now, this initiative was really a very major collaboration across many schools, departments, individuals, and entities, but the Office of Research in particular, IGM, DBMI, Pediatrics, Medicine, and other departments, Systems Biology. Wendy, Cho, and Christoph Kirkel have presented previously and have been the key operational leaders, but many, many others have been involved, a huge effort. On the community front, there's been a lot going on, in fact, probably more here than in many other areas. And these have included research projects and grants, education, and consultation in community, outreach and engagement and dissemination of information about COVID and services to the community, and service itself. So for research projects, for example, COVID symptom app tracker with NICE residents has been used with developed with G.Day Williams. We're now very much engaged in major underrepresented population grant initiatives with NIH called the RADx, Underrepresented Populations Proposals, where the CTSA is taking a lead on those with others. On the education front, there's recently finished with G.Day Williams and Liz Cohen a contact tracer certification class to help contact tracing in communities. And then with Rafi Lantigua and Harold Pink of Co-Director Institute, there's been a mental health initiative, which is with Columbia Psychiatry, but also the community in the hospital in Northern Manhattan that continues to evolve. And Rafi Lantigua has led major service initiatives with politicians, with community-based organizations, and with media in the community. And with that, I'll stop and pause and take any questions. I will point out that, again, that our institute is an interdisciplinary, programmatic service and support, research support for clinical and translational research, from preclinical basic genomic right through to community and dissemination and implementation science. And we've over 70 faculty involved and 60 staff that works with some programs, and we help to connect to the national network across NCATs for CTSAs. My email address is at the bottom. You can find all of this information on our Irving Institute website as well. And I welcome you to visit the website or email me with questions or any around what we're doing for COVID, or more generally what we're doing for clinical translation research. And I'll stop.
Thank you, Muredach. Great compendium of all the amazing resources that have been amassed. Okay, well, maybe I can just, maybe add, and you can confirm, Muredach, that because of the significant effort that is going on in terms of sequencing and profiling the samples, that this data will become available to anybody, both on campus and externally. And so that's one of the reasons why we prefer to go with a synchronized profiling, because otherwise doing it piecemeal would result in very significant batch effects, and probably would be harder to generate relevant data. So hopefully this will provide the fastest path to having the DNA and RNA profile data.
Yeah, I think from the biobank perspective, the initial responses and reaction on campus was that everybody was trying to do everything at the same time, independently, some collaborating, but many people trying to get samples. And it was very difficult for the Office of Research across the medical center to get organized around it. So we worked very much with many people, including yourselves, but the Office of Research, in particular with Mike Shalansky in the Dean's office, trying to organize and set up an infrastructure. And this includes a governance committee, a steering committee, and then subcommittees on genomics, on sample access. And these have already been established for the last couple of months and are really helping with the governance. Now, in this case, for DNA level data, the whole exome sequencing of the first 1500 is complete. That data will be available to people who submit for further data through a IRB approved process to get genomic data for their protocol, and to the biobank, and will be made available to those investigators internally, sharing the data within the campus as soon as their IRBs are approved. And that should happen in the next several weeks. Essentially, people will probably be more delayed by the IRBs than anything else. Secondly, we will be sharing these data externally with large initiatives, both national and global, around COVID, so we can have an impact collaboratively, both in the private sector and the public sector, NIH, Global Consortium, and industry, and New York Genome Center, for example, as well. And that stuff will probably start a little bit after the initial wave of sharing on campus. RNA sequencing is really working in two ways, around the viral side and then around the host side. And that data, we hope, with your collaboration and Katrina's collaboration, will become available in the next several weeks to a month or so also, but systematically generated. And some of the materials, as you know, have very low quality RNA because of the fact that we're predominantly residual samples coming through pathology. And that's the basis, the main basis of the biobank materials has been residual samples, although we're now collecting some prospectively.
Thank you.
There is a biobank website, and you can apply and you can look for contact and have conversations with our team of managers who can help you navigate the process.
So I see a question by Rodney Rotsney.
Muredach, thank you for giving us all that information. I was curious as to whether there's going to be sequencing of the viruses that the patients had as well. Is that going to be made available, and is anybody studying that?
Yeah.
Yeah, so Katrina Ullman, who's in infectious disease and Department of Medicine, has been focused on generating viral sequencing data from the NP swabs that were collected. She's already generated some pilot data. She's currently generating the next wave of data, and these will ultimately be made available also. You know, I think that, and Andrew could comment on this a little bit, I think that, you know, this area is very competitive. There's already a significant amount of work being done in this area, but that data from Columbia will be generated and made available, as is similar data from other centers in the city and elsewhere.
Yeah, I think just to add to your comments, so viral genome data is also available through the RNA sequencing that we're doing. And I think the big advantage here is that given the number of patients and the clinical history of this patient at Columbia, which is probably one of the largest sort of collections of COVID-19 patients, the ability to have these genomes, these RNAomes, will actually dramatically impact their ability to do phylogenetic profiling of the sort of virus evolution in the population. So that will be very interesting, Rodney. But we're all waiting anxiously for the data to be released.
Yeah, I will add that a closing slide I didn't manage to show in somewhere, but the Irving Institute CTSA has supported over 20 grant applications to date. And so a couple of those grant applications have been specifically focused on, 7 of those grant applications have been significantly focused on the biobank. And a couple of them have been focused on integrative genomics, which will bring viral genome, host DNA, and host transcriptome into a framework of trying to understand the interactions that are occurring within this fairly large resource. But getting the data out as quickly as possible is one of the missions in the next weeks as we're moving forward.